Hello?
Hello, sir.
Oh, there we go.
Yeah.
Hi, everybody.
Uh, the event is not started yet.
Oh, okay. Yeah, apologies for that. I had some significant connection issues. Of course, I could not get online. I think there was something with the internet in my area was down. So I think it's working now. Thank you.
Yes, sir. No worry.
For agreeing to be a guest speaker for our meeting. And so as I wrote to you, so CBD has been finally. Are you able to hear me, Dr. Evan? Are you able to hear me?
I can hear you.
Okay. Yeah, fine. So without any further delay, we have a lot of online participants waiting. This is a hybrid meeting because it's being a working day and a lot of traffic in the evenings. Many people selected to attend online. So without any further delay, I will introduce our chairpersons for the meeting, Dr. Pratibha Singhi ma'am. Ma'am is the president of ICNA. So she is a ex head of the department of pediatrics at PGI Chandigarh, and currently she's working at Amrita. She's the director of pediatric neurology there at Amrita Institute of Medical Sciences. And along with her is Dr. Aneja. Dr. Satyendra Aneja, ma'am, retired as the as pediatric neurologist and head at Lady Hardinge Medical College. And so I over to both of them. They're both very experienced pediatric neurologists and epileptologists. I hand over the session to them.
So, good evening and welcome everybody, physically and online. So it's my pleasure to introduce the speaker for today's talk. Is Dr. Evan Cole-Lewis. Is a medical director of Numinous, Toronto. And he's also assistant professor, Department of Pediatrics in University of Toronto. Is chief medical advisor of JMCL Group and VP of psychedelic neurology at Numinous. So I think he has expertise in medical cannabis, and that is a special strength for various neurological disorders. He has worked specially for cannabis in epilepsy and functional seizures, and he's also a co-investigator for two medical cannabis trials which are going on, and one of which is on chronic headaches and another one on drug-resistant epilepsy. So it's very apt for him to be present to give a talk on this meeting, because I think he has got the maximum, I was told he has got the maximum expertise regarding medical cannabis, even within the state of Canada, country of Canada and city of Toronto. So over to you, Dr. Lewis.
Thank you very much for the kind introduction. And thank you for having me here today. It's an honor and a pleasure. And apologies for the late start. That is on me. Of course, whenever we want to do something like this, technology tends to not cooperate, but I managed to get it to cooperate with us today. So thank you once again. I will share my screen now to ensure that everybody can see. So there should be a main slide here. Is that visible? Just to confirm.
Visible. It's visible.
Perfect. Okay. Oh, it's getting ahead of me. There we go. Okay. So there's obviously lots to cover on this subject, and it's very difficult in my experience when I teach on this. I teach on this quite often to know where the audience is at and to really get a sense of the knowledge out there and where to start and what to cover. And we could speak all day on this subject from the amount of information that I have, and to do this in a very short period of time does it an injustice. However, I'm going to touch on some very key points, and then we can raise questions thereafter, what we can discuss going forward. And so the focus today will specifically be on CBD in the context of epilepsy, as I know this is a new avenue for everybody. And very fortunately, you have access to this now, which you're going to see why. So the outline, if we can get through this, we probably won't have the time, but certainly we can cover some of this in the Q&A. So everyone must have an understanding of the endocannabinoid system and to really get a sense of what we're doing, what the oils are composed of. So what exactly does it mean to have a CBD isolate? And then how do you dose CBD in adult and pediatric epilepsy? And maybe I can leave these parts here, the tips and the beyond epilepsy, for the Q&A if anybody's interested. I'm yet to be tasked with a question that I don't have an answer to on this subject. So feel free to ask anything else beyond this. I've got many slides on different parts of this. So to very quickly, very, very high level, we're going to start at the endocannabinoid system in epilepsy. This is the most superficial explanation you will see of it. It's a system. The endocannabinoid system is a very intricate system throughout the body. It has receptors, it has ligands, it has enzymes, and you can see it's quite diffuse. And these are just two receptors amongst many others that are related to the endocannabinoid system that are disseminated throughout the body. So that's just a big high level idea. This I always like to discuss. This creature up here is the golden mouth sea squirt. It's quite an ancient creature. It's about 400 million years old or greater, and it has an ancestor, this chordate here, which we're dating at about 500 million years, which gave rise to the tunicates, which is the golden mouth sea squirt, and gave rise to the vertebrates, which is us up here. Well, this interesting little tunicate, the golden mouth sea squirt, has an endocannabinoid system, and we have an endocannabinoid system. So one can presume, or that implies that this ancestral chordate had some primitive development of an endocannabinoid system. So the endocannabinoid system is hundreds of millions of years old. And whenever we have that, that piece of knowledge disseminating through, it tells us that this is a really important system and perhaps a fundamental system. So to put that system into context, what really is the endocannabinoid system doing? Like, how do you conceptualize it? How do you think about it? And the way I like to discuss how to talk about this, and many people in the space talk about this, is that the endocannabinoid system is your fine-tuning system. It's diffuse throughout all physiological processes, more or less, and it's responsible for the fine-tuning. And that's a really important idea fundamentally to understand what we're doing with epilepsy versus some of our other drugs that we have available to us that are more large-scale modulators of systems and neural communication. So this is why cannabis is so special, because it's acting on this very special system that is responsible for fine-tuning. Let me give you one quick example. If I strike my hand, on a table walking by, and I hit my head, and you get that little tiny bit of pain, and it kind of goes away, that's your endocannabinoid system. If I was to take a hammer to my hand and accidentally hit my hand and depress that tissue, fracture bones, that's the opioid system that comes out, because that's persistent long-term pain. So there's a nice little difference to kind of get a sense of contextualizing. And then that's how this works in the context of epilepsy as well. So what are the cannabinoids and non-cannabinoids? Well, you have to look to the plant, okay? This is the flower of the cannabis plant, and the flower is where all the cannabinoids are housed, okay? They're not in the leaves, the roots, the stems, the seeds. They're not there. They're in the flowers. And if you take this flower and you blow it up, you're going to see these little structures here called the glandular trichomes, little mushroom-like sticky structures. That's where the cannabinoids are found. And if you take these glandular trichomes and you break them down, you get a series of different compounds. You get non-cannabinoids and cannabinoids. The non-cannabinoids are your terpenes and flavonoids. What are those? Those are plant molecules, so not specific to cannabis. They're plant molecules, and they provide taste, smell, and appearance to a plant. So an example up here, here's a nice little wheel of some terpenes. Caryophyllene is a terpene that's found in pepper, so black pepper. Pinene, that nice pine scent you get from coniferous trees and pine trees, that is terpene. Limonene is another one. Citrus smells you get on oranges, you smell that. It has a nice anti-anxiety effect and properties to it. And some of these terpenes may be contributing to the effect of epilepsy. It's still, this is a big area of study. Okay, so we have our terpenes, but what about the cannabinoids? Well, there's about 130 odd that have been identified now. There continues to be more identified. These are more specific to cannabis, although some of them have been found in some other plants as well. How do you break these or classify these? I like to look at the euphoric ones, the ones that give that sense of euphoria or high. That's where delta 9 THC sits, and there are many other cannabinoids that sit there as well. The others on the other side are non-euphoric, and the non-euphoric cannabinoids, the ones that don't produce that high feeling or that euphoric feeling, that is where CBD sits, cannabidiol, and there are many others. So I don't really prefer the term psychoactive, non-psychoactive, because it's a bit of a misnomer. People often use that. This is why I like these two terms, because CBD is certainly psychoactive. It goes into the brain and helps with seizures. It's working on the brain. It helps with anxiety and other, alterations of perception. So it's certainly a psychoactive molecule. It just does not produce euphoria. So it's a little bit of a better semantics to use, I think, when it comes to this. So what is actually in an oil? Well, what is it? So what's in an oil is you take these flowers and you put them through a very significant extraction process with perhaps some purification, and you derive an oil. Well, how, what are in these things, and how can we separate them? Well, a nice way to look at that is to just look at the different components, which I've already told everybody. So an oil is made up of some amount of CBD, some amount of THC, typically depends on the oil, and then a smattering of all those other components I talked to you about, all those other compounds that are there. And so all you have to do is vary these proportions and you get different types of oils. So as an example, on one side, we can have oils that have a non-significant amount of THC. So less than 0.3% is determined non-significant. And you've got two kind of major groups here, right? So this would be an oil that's kind of like mainly CBD with a little bit of everything else. So those that fall between 0 and 0.3% are called full spectrum. This is very important. The terminology is so important here because this gets really misconstrued in the literature. On the other hand, those that almost are THC free, so they go through another process of washing out THC, that can give you a broad spectrum oil. Or if you really wash it very clearly and you get rid of all the other components, all those other minor cannabinoids and terpenes and flavonoids, you have an isolate. And this is cannabidiol. This is Epidiolex. This is the medication that we are talking about, or that's going to be available to you, right? On the other hand, in Canada, we have many different products. So I have a lot of products that have THC in them, and I could use those as well. And they can just vary in terms of their composition. And that can be a THC dominant, a CBD dominant, or a balanced oil, balance between CBD and THC. Another way to visualize this, I'll show you very quickly, is something like this. You go through a process, you get a purified, or you get an isolate, a full or a broad spectrum, right? And here are some various different products that are available. None of these I have any kind of attachment to. I didn't mention my disclosures. I'm just showing them up here for purposes of examples. And on the other side in Canada, as I said, we have many different products here that are useful in different circumstances. And there's just a couple that you might be familiar with in Europe, Canada, and Israel, etc. So that's another way of looking at this. Really, really important to understand the context of the medicine in which you're using. Okay, so how do we initiate, right? So you have a background on what these are. How do you initiate CBD dosing in an adult and pediatric patient? Well, let me give you a bit of a history of this. Is one of my first patients that I ever treated. This was a little girl, 2 years old. She had this explosive onset of drug-resistant seizures. Very, very typical of these type of patients. Normal MRI, no genetic etiology discovered, but she had terrible seizures and started to lose skills, really presenting a lot like a Dravet patient, for instance, but she was not. We started valproic acid that helped with daytime seizures, but we were just unable to control the nighttime seizures. So we decided to start cannabis for her. So this is just a very brief look. This might be presented today, but this is the data from the various different Epidiolex trials, all the trials that were done on the CBD isolates. And you can see in these various different conditions that the use, this is a percent reduction in seizure frequency here. This is placebo. So you can see the green bars are statistically significant over the kind of yellowish bars here, the placebo. What's important is dosing, right? So this is 20 milligrams per kilogram per day, 10 milligrams per kilogram per day, right? 20, 50, 25, 20, 20, 20, 10. So there seems to be some sweet spot in between 10 and 20 milligrams per kilogram per day to achieve an effect. So that gives us a little bit of a clue on dosing. And this is the dosing, this is the evidence that I've used to develop very specific protocols that I have at my clinic around epilepsy. Another way to look at this is to put it all on a nice big table. And what I like to show here is these are the 5 different studies. Okay, there's 6. This study here was a phase 1 trial. So 1, 2, 3, 4, 5 were more of the phase 3 trials. But what's important to look here is the number of patients is quite high, and the number of adults is also quite high. So there's some good adult data in mixed into here. And the other piece here is the milligram per kilogram per day doses that were used in the different trials. So you can see the bulk of these doses were between 10 and 20 milligrams per kilogram per day. Okay, so that's just another way to visualize all this. So therefore, what do we do? Okay, well, the most important thing for me at the time when I started doing this, which was several years ago, was it was still a bit controversial. So I really had everybody do a consent form based on your institution and how you feel about this. This is something you might do, but I mean, I think with the pharmaceutical grade CBD isolate, you're okay here. Baseline studies are important. As a note, ECG I use just because I use THC in some patients. With CBD, you do not need to do this. You have to think about your concurrent AEDs. You have to have a plan around dosing. What's your target dosing? Depending on what's available, so in Canada, again, some oils have THC in them. We don't have to worry about that here. And then how do you track? What are you doing? So in terms of monitoring for CBD and THC, in terms of other anti-epilepsy drugs, there's a lot of information out there. We know a lot about this. So that data is all out there. And here is a nice breakdown of cannabinoid metabolism. Again, not really for anybody to memorize, just to show that we have good knowledge of the CYP450 enzymes that are involved in cannabinoid metabolism. Therefore, we know the interactions. And here's another table. I'm very happy to share this with anybody who wants it thereafter. Here are kind of some major epilepsy drugs, maybe warfarins there for those who are treating adult patients who might be important, and some of the interactions here. So the biggest interaction to note that is most, I guess, specific to practice is clobazam. Clobazam will elevate in the context of CBD, and valproic acid. Valproic acid itself will not elevate, but you have to watch for concurrent elevation in liver enzymes when valproic acid is used. And these are the 2 most common examples that I deal with in my practice, pretty much on daily, and have to make adjustments accordingly. But what you do is you approach it like this. You do some baseline blood work. So I do some baseline blood work, and here's my panel right here, okay? You won't see this elsewhere. I do ammonium and TSH, particularly for those patients on valproic acid, because I have found with the valproic acid, if you start to get elevations in liver enzymes, you start to get elevations in ammonium and TSH in the context of CBD. So I'm a bit cautious. I'm overly cautious, perhaps. And this is kind of my process here and what I track. Right? And here's kind of the known interactions that are kind of more specific that you might see. So then it comes to dosing. What do you do about dosing? Well, there is some guidance in the literature, as I said, and here are the ranges you can find throughout the literature. So the childhood epilepsy range is somewhere between 100 to 300 milligrams a day, and adult epilepsy is between 300 and 600. And you can scour the literature, and these numbers are pretty consistent. So I think of those as my goalposts. I'm aiming for somewhere between these ranges. So that begs a few questions, because you're going to receive a drug monograph with very specific dosing. But it's a good that that's there and it's from the trials. But when in practice, sometimes that doesn't always play out. So let me give you an example. So this here is the dosing guidance for the current medication you will be receiving, but it also is the same dosing guidance for Epidiolex. So this is pretty standard that has come from those 5 trials that I showed before, where you initiate with 2.5 milligrams per kilogram per day, BID, so 5 milligrams per kilogram per day, and then you increase accordingly, right, depending on the conditions here that's being used, increase accordingly to a maximum. Okay, well, 25 milligrams per kilogram per day is quite a lot of CBD if the child is large. The child weighs 50 or 60 kilos. So if you're talking about an adolescent, those are huge doses of CBD. So this is where I kind of step back, and I'm not sure in practice this doesn't really pan out because you're just going to run into side effects. So in my practice and time, I created an inflection point, and that's where I said, okay, at which point do I switch from weight-based dosing to basically standard or fixed dosing? And the magic number for me is 30 kilograms. Why is that? Well, let's go back to our dosing and look here, right? Well, 30 kilos conveniently at 10 milligrams per kilogram per day becomes 300 milligrams. So if you go and look at the data, 10 milligrams per kilogram per day to 15 milligrams per kilogram per day, about there, that is a dose response for me. That is an average dose response where I'm not getting over side effects and actually get a response. It's with the evidence, it's with our anecdotal work that we're doing at my clinic as well. So for me, 30 kilos is the inflection point. So this is my dosing protocol that I use. So when I use CBD, and we start off everybody with phase 1, I aim for 10 to 15 milligrams per kilogram per day, very much in a titration schedule as we saw previously. But I do that for all those kids less than 30 kilos. If they're over 30 kilos, I switch to a fixed base dosing, and I'm just going to 300 or 450 milligrams. In my experience, let me take you to phase 2. So phase 2, so if they do not respond or are subtly responding, you can titrate that up and optimize it to 20 milligram per kilogram per day for those less than 300, and up to 600 for those more than 30 kilos. And again, why this magic number? Well, 20, you do the math, and at 30 kilos times 20 gets you 600. So this is why 600 is the kind of max ceiling for me. For me, I find if there is no response by 20 MKDs, just to clarify, MKD, milligram per kilogram per day, that's my short form. I prefer using that. So if I have no response at 20 MKDs and 600 milligrams in a person greater than 30 kilos, in my experience, it's very unlikely you're going to get a response. Now, if you have some response, then you can continue to titrate up beyond that, right? And you can kind of continue to explore. In Canada, though, we have access to different oils, so we typically go to a phase 3 and we start to play with some of the other cannabinoids at that point in time. But this I think is for me, it's worked in our situation. So I'm going to just very quickly just discuss the side effects, and maybe we'll pause there to see if that would be a good enough time given the timing, because I know we're a little bit late to stop here and I can answer some more questions. So I'll very quickly just mention this. What are the side effects of cannabis? Or, in general, this is a really nice study that, looked at kind of comparing many different, illicit drugs, and look where cannabis is. So this is cannabis, this is with THC, sorry. Oh, there we go. This is with THC. So this is not the CBD isolate you're working with. You actually don't need to worry about dependency with CBD isolates. There's no data showing dependency, but this is just a good place to look where cannabis is, even when it has THC, on the relative safety of cannabis. Because back here on the x-axis, this is basically a measure of lethality. It's active dose over a lethal dose, and no one in the history of the world has died directly due to cannabis. They may have utilized cannabis and then done something, taken actions that have impaired their perception, and then gone off and hurt themselves or have died in that sense. But physiologically, no one has ever died from cannabis. And dependency is an issue, and that's when it has THC. Not with CBD. CBD is not a molecule that has shown to provide dependence at all. Adverse effects of CBD. Here they are. These are from the studies. Really common: diarrhea, tiredness, decreased appetite, especially when you get above the 400, 500, 600 milligram. You're going to see specifically tiredness, right? Long-term adverse effects, it seems to be very well tolerated. And we've got data that extends out to about 5 to 7 years now. These are the last 3 important points, and then I'll kind of stop here. So the 3 important points are this: that cannabis needs to be stored in a cool, dark location. So CBD should, because it can break down. You are fine to operate and drive a vehicle on CBD. It does not have those euphoric effects. Be very careful with travel, even with the CBD isolate. I don't know the rules in India about leaving India with a cannabis-based product, but you cannot leave Canada with a cannabis product, and you cannot enter into a country with a cannabis-based product as well. Even in countries where it is legal, as far as I know. So that becomes a real issue with having to help patients find sources of CBD in alternate locations. So I will stop here, and very happy to take some questions around what we've discussed, and happy to expand on anything else that I've discussed today.
Thank you very much, Ivan, for that very lucid and right from basic to the practical points. I think that's the beauty of your talk, that people who have not been, familiar with cannabidiol can actually now understand like what it is, clarifying the basics and how to proceed with actually managing a child or a patient who needs this. The important things are, of course, the dosage modification, making sure that you are choosing the right patient, and stopping when you need to stop, and escalating when you need to escalate. And I think you brought out those points very well. So without much else, I would open to comments and questions.
Yeah, thank you. I'll just say one thing to in response to that. Very, very, very important, because I didn't mention this. And that's it, just to kind of follow up with this. Cannabis, CBD, cannabis, to me is an anti-epilepsy drug, number one. That means that all first principles of epilepsy care apply. Do not treat this any differently, any more special, right? Treat it as an epilepsy drug and put into context how you care for children and adults with epilepsy. And that will be very helpful. I don't raise it to any kind of special significance, nor do I lower it beyond my other drugs. I put it into context, and all first principles apply.
Extremely important. I think that's an extremely important message.
I think I'll have to ask one question. In USA, I saw that it was approved for children more than 2 years, excepting for TSA, where it was for 1 year. Any reason why this was a differential between the two conditions?
Yeah, that's just based on the data from the trials, as far as I.
Okay, and the doses are same for tuberous sclerosis, or?
No,
response,
so that
and response also I saw was a little different.
Yeah, so I will. Here,
you just tell us some of your experience.
Right here, so I can go back here. Okay, so you'll see here, right, in the TSC trial, they use really big doses. I can't remember the rationale for this here, why they did this. It probably came out of some ideas or a mechanism, anecdotal report. I actually don't know. It's a good question, but they certainly use really large doses. Like, look at this, 50 milligrams per kilogram per day. And this population saw more side effects, but look, equal efficacy in terms of seizure reduction. And I would warrant a guess, if this number was 10 or 15, you're going to see very similar efficacy. So in my experience, and I've treated many TSC patients, they do not need these doses. They really don't. That's my experience. But if you go to the drug monograph,
Dr. Evan, the shared screen is not shared. Please share the screen.
Oh, I'm sorry. I took it. That's I don't know why that happened. Okay, sorry. There we go. Are we back?
Yeah.
It was sharing during my talk, though, right?
Yeah, of course.
Okay. So sorry, this is what I was just showing everybody. In this TSC data, you can see, right, they use 50 and 25. Equal efficacy at 50 and 25 milligrams per kilogram per day. So no difference, right? And if you look at the Dravet and Lennox-Gastaut, 20 and 10, also non-significant differences in seizures, right? So it almost, this begs the question, do you even need doses this high? In practice, and that's why I altered my protocols to 10 to 15 milligrams per kilogram per day. And I even find some patients respond with even less than 10 milligrams per kilogram per day. So that tells me, when we go and we look at the drug monograph here, this is nice. I think this is a nice general guide. I titrate much more slowly than this. I do it because I want to capture the CBD responders. So a lot of CBD responders are around 7-8 milligrams per kilogram per day. And what happens is if you skip that and you get to the 10 or 15, you might cause side effects and you might make a patient discontinue. So the number one reason for patients to stop Epidiolex or to stop CBD isolate that has been studied is from side effects. So I don't want to miss the boat there. And so I titrate a little bit more slowly to capture perhaps in between 5 MKDs and 10 MKDs.
And if you taper it, how quickly can you taper it off?
Good question. So very quickly, I find CBD isolate, you can taper quite fast. So if you have to do it in an urgent situation, you literally can do it within a week. Now that's urgent. If you don't have an urgent situation, then if you're at a dose of about 300 milligrams, so 10 milligram per kilogram per day or a little bit higher, you could do that by reducing by about 2.5 MKDs or about 50 milligrams every 3 to 4 days. That's a great question. I should put that on here for a taper. But again, that's very important in an emergency situation. I've found that I've been able to taper it quite quickly.
Well,
Now, of
thank you
course,
so
that's going to
much.
depend. Sorry, that's going to depend on seizures, right? So you just have to monitor for seizures. Again, first principles apply.
So we had some questions. So can you share your protocol of how you start and titrate, or would you be happy to email it to us later? Okay.
I certainly can. What I'll do is I'll stop sharing and then I'll see if I can pull it up and then I can show everybody while I take other questions. So let me do that.
Okay. One of the other questions was like, how long would you give it to realize it's working or not? Like, if you're writing it really slowly, is there a period of time that you take?
Yes, certainly. First principles, right? So I would beg the question, or I would respond to that is like, how long would you monitor valproic acid or carbamazepine or anything? Again, no special significance here, right? Medical cannabis or CBD, if it is going to work, you should see it work just like our other epilepsy drugs. So that would be my answer, whatever your practice is, and right. And I don't think the literature is showing anything different. In some cases, I've had patients respond immediately, like within a day or two. That means their epilepsy was intimately tied to dysregulation in the endocannabinoid system, and the addition of the CBD regulated the endocannabinoid system and stopped the seizures. They had seizure freedom. And so I would, just replace that with valproic acid, and you do the same thing, or something else.
And have you noticed any interactions with the ketogenic diet? Like,
no. Yeah, that's a good question. No, I have not noticed any reduced efficacy of ketogenic diet, or on the other side, increased efficacy of cannabis and ketogenic diet when in combination. I've not noticed that. They certainly can be combined with no concerns. So that's you, but of course, discuss with the ketogenic diet team that you're working with, or to ensure that the product is okay to be mixed in and kind of with appropriate counts, et cetera. But I haven't noticed any, worsening or improvement. Unlike, I would say, again, this is completely anecdotal, and we are actually going through all of our data. We will soon have published about 140, 150 children on cannabis. That should come out in the spring. It's our data we've come through. Anecdotally, valproic acid and cannabis are a good match. I find that tends to work well together, and clobazam as well. But then the question is it really just elevating the clobazam or making the clobazam more, available in the blood levels because it increases blood levels? Hard to say. But I do find the combination of, totally anecdotally, of CBD and valproic acid seems to be helpful. But you have to watch for the liver enzymes.
Thank you.
Another question that I wanted to ask, what is your protocol when you started with, say, clobazam? How do you manage those two drugs together? And is there any other drug which has practical significance when we are adding CBD to it?
Yeah, great question. So for clobazam, I will always do baseline blood work first. So that way we have a baseline. And then you can start. And if the child gets very tired or the adult gets very tired, you've got baseline clobazam levels. you could at that point just hold the CBD dosing, do another level, and see if it's elevated, and then you have your answer. They never get, I have not had a single patient with extreme fatigue and tiredness. It's a gradual process that the parent will identify. So as long as you counsel the parent or the patient ahead of time, you should have no problem in picking that up and subsequently managing that if you have to lower. So how would I do it at that point? Well, then I have to, again, first principles, make a decision. Is it do I believe it's the cannabis that is, I could lower to preserve seizure stability, or is it the clobazam? So let's say this person was on clobazam for quite a long amount of time. I added cannabis, they got really tired, but their seizures improved a little bit. I'm like, oh, okay, well, I'm going to lower the clobazam and keep the cannabis on because that seems to be working, or vice versa. Again, this is a first principles type of concept. Now, I do have a personal clobazam dose in which I reduce the dose preemptively. That is 20 milligrams BID. I find at 20 milligrams BID, that is a pretty high dose of clobazam that once you add CBD, you really do elevate the clobazam effect. So 20 milligrams BID for me is an automatic preemptive dose lowering. I lower it down to 15 milligrams BID and while concurrently adding cannabis. So I kind of do those things simultaneously. That's the only little thing that might deviate a little bit from basic first principles, in epilepsy care, because it's not common to do things like that in my practice, at least. So that might just be, that might be a bit of a deviation, but that's what it is. So remember, my magic number is 20 milligrams per kilogram per day. And I just pulled up my epilepsy protocols. If you'd like to see it, let me reshare the screen here. So this for everybody to know is our protocols that we're actually going to be publishing very shortly. So these will be available for everybody. We're going to very likely publish it through the Medical Cannabis Clinician Society in the United Kingdom, where I'm an executive member. That society will likely publish these protocols. So everybody, you're getting a sneak peek and a glance here on these protocols. So this is kind of what I do for my phase 1 CBD. So you can see so this table up here is your total dosing. This is a CBD dosing split by 30 kilos. So my morning and evening, you can see I dose up to 7.5 milligram per kilogram per day. So this would be a total of up to 15 milligrams per kilogram per day, right? Or 450 if they're over. Okay. So again, that's just the maximum that for this phase, that's not go to here. And now if you'll see the titration, so see my titration schedule is weekly by, we start at 1 MKD and then I go up by 1.5 MKDs weekly. So this is a lot slower than the previous titration schedule. On the 30 kilo side, I go up by 50 milligrams BID, and we do that slowly. So the reason why this is slow is to capture that the CBD responders that might respond to lower dose. And then the phase 2 of this is the optimization dose. So you can see I'm just optimizing the dose up here, as I talked to everybody before, 20 MKDs for the day, 600 milligrams, and again, slow titration. So there they are there. I'm trying to remember what phase 2B is. Okay, so phase 2B, I say like, okay, if I get to 20 MKD, so if I get a patient to here and I'm seeing progressive response, then I open the door to really go up to those tuberous sclerosis type doses that you saw before. I will tell you though, in my practice, rarely do I ever take a patient through 2B. You don't see it. It doesn't really pan out that way. I hope that was helpful.
Just a question. Expanding the spectrum of use of cannabidiol, it is approved for tuberous sclerosis, Dravet syndrome, and Lennox-Gastaut syndrome. Since it does not have a specific mechanism of action particular to these 3 diseases, do you think it can also be used in other difficult to control childhood epilepsies? And secondly, what kind of seizures? So there is different types of epilepsies, and then there is second thing, different types of seizures. So what are the types of seizures it mostly targets, and what is the most, because we know these are difficult to control epilepsies. So what is the most appropriate? We are not achieving here seizure freedom. So we are trying to improve the quality of life. So my question is, what are the type of seizures which we are aiming at? Means the optimal seizure success, we can say in this case, what do you achieve for?
Wow, yeah, a series of great questions there. So, and I'm it's almost like we planted this question because I didn't get to these one set of slides that I really wanted to show everybody, which I'm going to show you in response. Okay, so the question, number one question was about the type of epilepsy syndromes. So I'm speaking very much off label right now. I mean, but I'm able to do this being from a place in Canada. So I would say it's actually true. If we look at our data that we've collected, the majority of patients I treated are not Dravet, not Lennox-Gastaut, and not TSC. They are unknown etiological epilepsy in kids and adults, and who are drug resistant. In very, very few cases, I've started first line or second line. So in some cases, non-drug resistant, but that's just because I've been doing this for a very long time. And I have a harm reduction approach that I take with patients. That's for another talk for another day. So there is a role. There is a role in drug resistant epilepsy. And I'm going to come back to this in a moment and tell you what my thinking is about that. Number two, what types of seizures? In my experience, and this is kind of panning out in the literature, motor seizures, generalized. So generalized motor seizures look to be the most responsive. Next, I would say kind of focal motor to some degree, maybe not. What focal epilepsy has been a challenge with cannabis. It hasn't really proven in the literature. And I find that I get like some response, some don't. The least response is absence seizures. So absence, be it childhood absence, syndromic absence, or even absence in the context of Lennox-Gastaut or kind of more typical absences, I find not really good response. And the least responsive are myoclonic seizures. So generalized motor seizures are kind of like the bread and butter, those that have normal MRIs. So probably from genetic and unknown etiologies. Now, I said I was going to come back. So you said a really important thing, and I'm going to very respectfully disagree with you. And this is so important for everybody to contextualize, because this is what it's been my experience, is the question of seizure freedom with CBD. So to think that you are doing this to improve quality of life is absolutely the wrong angle to take. Remember, cannabis has come to us very fortunately as an alternative epilepsy drug. It is an established epilepsy drug that works on a completely independent system. So in fact, achieving seizure freedom is a distinct possibility. And all you have to do is look at all those 5 trials I showed you. They had a seizure freedom rate of between about 5 to 8%. Okay. And when you look at other trials, okay, so this is a trial from the UK that looked at CBD isolate and CBD with THC. But if I fast forward to the results, these are 35 patients. Look right here, you have 50% reduction with CBD isolate. So 31% patients, a 50% reduction. But look at this. This is the key piece in every single cannabis trial. I want everybody who's reading these trials to go back, focus on the seizure freedom. This is one patient out of 35. Okay, so that's 5%. I mean, those are very small numbers, not that great. But this 5% number there pops up in a small sample. Now, if we look to our data that we've done, so this is our data in our interim data analysis, and we look at our seizure freedom, here are some baseline characteristics. We had 9 patients. This number has actually gone up to 15. 9 patients who are seizure free. Here are their etiologies. These are very drug resistant patients, various different ages, and here we go. 2 patients with CBD alone, okay, 2 out of our 121 became seizure free. This is a little bit of a lower number, but when you add THC, you look like that number goes up to 9. But given that you only have access to CBD isolate, you've got 2 patients. So here's my main message about this, okay? My main message about this is that it is about seizure freedom. It is about reduction of seizures. Remember, this is acting on a unique system, that fine-tuning endocannabinoid system. So these numbers now are so consistent to me, and we're actually publishing a paper on seizure freedom in cannabis that should also come out in the spring as well. This is such a consistent finding for me that I now say this. I say, look, if you have a group of patients in your practice who are drug resistant, who have never tried a cannabis interaction, you were actually sitting on a group of patients with a 5 to 8% chance of seizure freedom if you employ cannabis as a trial. So I really want everybody to see these numbers. This to me is always gets overlooked and is the most important numbers that come out of the data for cannabis.
Thank you for that nice elaboration on this. We know it's an add-on. It's an add-on drug. So what number it comes at in your list? Means you started at number 3, number 4, number 5, or number 2, or you start at the onset in a combination?
Good question. Okay, what I do might not be what everybody else does. I'll just leave this up for now. What I do might not be what everybody else does. What I being involved in cannabis for a very long time and coming into cannabis in a time when it was very contentious and there were a lot of challenges and people were literally wanted nothing to do with patients who were talking about cannabis. I recognized that I had to change how I was taught and I had to change my approach. So I call myself a harm reductionist. I come from a lens, very much I practice from harm reduction. So I don't think there's a straight answer to that. I don't have a protocol in which I insert cannabis. I think I contextualize every situation. So let me give you an example. Drug-resistant patients, by the time they come to you, they've tried at least 3. So any drug-resistant patient, and given the seizure freedom data I just shared with you, to me, it doesn't really matter. I mean, again, insert that into your first principles of epilepsy care. Like, where would you put topiramate in that? Where would you put lamotrigine? You would do it based on your knowledge of the patients and the seizures and the evidence and everything else. So for drug resistance, that's easy. Just insert with first principles. And I think then you're not in a list. It just makes sense when it makes sense from your training and all your practice that you've had. Okay, well then what about second and first line? Okay, well that comes with practitioner experience. We're going to need more data to really flush that out. But if a patient comes to you who's horribly unwell, who is very educated about Dravet syndrome, let's say, or Lennox-Gastaut syndrome, and has some ideas about medicines and is really adverse against, about pharmaceutical drugs, et cetera. There's a whole host, right? And they adamantly do not want to start anything but cannabis. Or CBD, let's say, so the CBD isolate. They only want CBD and they don't want to talk about anything else. Here's my approach. This is my harm reductionist approach. Actually, after telling them all the information I have, if they, about saying like, we should try this drug because there is evidence here and this is how it compares to CBD, et cetera, et cetera. If they are still adamant about it, well, if I say no to them at that point in time, they will just go find somebody who will do it. Or in Canada, at least, they'll source it from somewhere else or some other doctor who might not be as expert in epilepsy as I am. So I'm almost burying my head in the sand and allowing that to happen. And for me, that's more harmful. So at that point, I ally with the patient and I help. And the same principle goes for first line. So I've had patients come to me who absolutely, for very good reasons, like these people have gone through very difficult, trying times. Their lives are not easy. Their kids are very sick, and maybe they've had bad experiences through the medical system and are very, worried about the medical industrial complex and the pharmaceutical agencies and industry and whatever your beliefs are, that's their beliefs. You're not going to change that. And so in that sense, I think it's better for me to be on board with that family. We go through a trial of cannabis, and if it works, it works. If it doesn't, then now they're more willing to work with me. So that's my harm reductionist approach, and that would be my answer to your question.
Thank you so much, Dr. Lewis. I think that was excellent. And thank you for answering all our questions. And we really thank you for your presentation. And so we now move on to the other sessions. We would be happy if you could stay on. We know we're running a little late, but so as per your schedule, it'll be happy if you could stay on.
Very happy to. Thank you.
Yeah, thank you. Thank you so much. And thanks to our chairpersons, Dr. Pratibha Singhi ma'am and Dr. Neja ma'am, for sparing time after their busy schedules and coming in this very heavy traffic. Yeah. We now move on to the next session, and I invite Dr. Mehendi Ratta sir. Can we have the slides? Sir, आप ही हैं, switch पर slide. So we have a very distinguished chairperson. Sir is the past president of IES. He's the ex-director professor, Department of Neurology, GV Pant Hospital, ex-director of Janakpuri Super Speciality Hospital. And I think he's extremely well known to this audience. So we can move on. Over to sir for the next session.
Thank you, Dr. Suhasini. Good evening, friends. International Epilepsy Congress 2023 was held in Dublin, Ireland, from September 2nd to 6th. And there were at least 5 sessions on developmental epileptic encephalopathies, covering all these 3 topics, and particularly covering the new kid on the block, that is the cannabidiol. In 5 days, there were 5 sessions, and many of the sessions were sponsored by the pharmaceutical company, which have FDA approved product in the market or are in the process of coming to the market. We often talk of these entities, these are in infancy or early childhood, but then we also talk of transition from childhood to adolescence and adolescence to adulthood. That's why this topic is very relevant here. That's use of cannabidiol in adult epilepsy. Because there will be cases of Lennox-Gastaut syndrome. We also talk of adult LGS. We also talk of, it's very common, tuberous sclerosis complex from childhood or adolescent to adulthood. So with these, there is very experienced speaker on this occasion, Dr. Manjari Tripathi, Professor Manjari Tripathi, my very dear colleague. We both were working together in Indian Epilepsy Society. And I'll also like to congratulate her and inform you that she has taken over as HOD, Department of Neurology at All India Institute of Medical Sciences, New Delhi. I think you all should congratulate her by giving a clap. You are not supposed to clap. Manjari, you are doing. So I'll also like to extend a invitation for, we are organizing Delhi Neurological Association conference on 3rd and 4th of February in India Habitat Center. We thought we'll move from 5-star hotel to eco-friendly place in 3rd and 4th, and you all are welcome in that. Registration is on. Request all or advise your residents to submit the abstracts for award session and platform and poster presentation. So I'll not take further time and invite Professor Manjari Tripathi to tell us use of cannabidiol in adult epilepsy after a very strong foundation has been laid by Evan Lewis in small children, growing children, and grown children about cannabidiol. Now she will talk from adolescence to adulthood. Dr. Manjari, please.
Thank you, sir. And sorry for being late because the traffic from Southex gate of Ames to here was 45 minutes. It was a nightmare. I had to turn and come through Kalkaji, and it was really difficult. But so cannabidiol in adult epilepsy, we as neurologists, we like to base our prescriptions on evidence. And somehow there's not too much of very robust level 1 evidence in adults. Nevertheless, we know that there is a transfer of patients from pediatrics to adults of various epilepsy syndromes. We know there is a shifting responsibility of Lennox-Gastaut syndrome, which eventually do become, say, 20, 21, or even older, and we do have Douze syndrome. So there are several of these syndromes in which it has been tried, and the adult neurologist has to be aware of its use, misuse, or abuse. And what's the difference between the medicated pure, cannabidiol versus the artisanal cannabidiol, which is available at every kind of corner in this country because everybody is selling cannabis and they equate it with using cannabidiol, which is not so. So the whole story of cannabidiol was fueled by a single person. And this was an anecdote which kind of took the internet by storm. And it was in all the press, all the media. And now that, there is this, there are now artificial intelligence bots. So if you want a news to be hyped, you just have to give it to one bot and it can be bought. So, and it can, make your Twitter or your Insta a million times much more. So this went on without those bots. This kind of news just spread worldwide about Charlotte, who's a 5-year-old girl in US and who had SCN1A confirmed Dravet syndrome. And she used to have almost 50 or more than 50 generalized tonic-clonic seizures in a day. So you can imagine the number of times she was falling, and the parents, especially her mother, was distraught. So she was started on a high cannabidiol strain of cannabis extract. And within 3 months of starting this extract, there was more than 90% reduction of her seizures. So this was what brought about this, revolution of management, which has entered clinical trials now from this anecdotal report of Charlotte Figi, which, circulated the World Wide Web as Charlotte's Web. But what about adults? So we're going to look at a little bit of the mechanism of action and then its evidence in adults. And I'm sure this has been dealt with. Basically, there are multiple targets for cannabidiol, and all these targets modulate neuronal excitability. As we know, most anti-seizure drugs work on this mechanism. So they reduce the neuronal excitability as well as the neuronal injury. However, there is strong evidence and some evidence for the mechanism of action. So if you look at the strong evidence for the mechanism of action, you can find that it works on the cannabidiol receptors. Mind you, all of us have endogenous cannabinoids. I hope you are aware of the endogenous cannabinoids, and that's what is released when we say exercise or when we talk positively or we do yoga or we do aerobics or maybe over a peg of whiskey or whatever. The endogenous cannabinoids are released. And all of us have cannabis receptors, and these endogenous cannabinoids act on this to make us feel good. So the cannabidiol works as a negative allosteric modulator of CB1 and inverse agonist of CB2. Apart from that, it has various agonist and antagonist actions. So for those who are going to take up exams, maybe you should remember this. It also works on the T-type voltage-gated calcium channels and reduces the presynaptic glutamate, which is what we wanted to do in epilepsy. However, there are several challenges which face us in adult epilepsy pertaining to cannabidiol, and the doses. So if you have to give similar doses in an adult who's say 60 kg or 70 kg, so you're going to use many more bottles of the oil, which is really going to cost much more. So that is a major challenge, I think, as neurologists we will face in our country in adults. So in the beginning, what I see is that we will have children who are proceeding to be adults, and they have been or have been started on this compound. We should learn to manage it. I also see many drug-resistant epilepsies being started on the molecule, provided they are able, quote unquote, to afford it. And certain genetic situations, like, we will see what genetic situations. So you could have an adult with that genetic mutation where you would be forced to use it. So basically, the highly purified cannabidiol is derived from cannabis sativa. And it has been subjected to well-designed randomized control trials, particularly in Lennox-Gastaut and Dravet syndrome. Whereas in adults, you can see that the level of evidence is not a double-blind randomized placebo-controlled trial. Most of them have been open, observational, prospective, cohort studies. So this is one such study where it was conducted in Argentina, and it consisted of 55 adults between the age of 18 to 60 years with drug-resistant focal epilepsy, which is what we see day in and day out, at least at AIMS. And the dose was slowly built up and maintained. If the patient was responding, it was not increased. But if the patient didn't respond, it was increased to 125 milligram per day. And you can see here that many of them were on the usual anti-seizure medicines, which we all use. So they were on levetiracetam, 66%, which was the most favorite molecule, followed by clonazepam, carbamazepine, valproate, lamotrigine. So basically all the other drugs which we are commonly using in drug-resistant epilepsy were being used in these adult patients. So you see the blue color here is the responder, and the green color here is the non-responder, and the very light yellow, which is at the top, very thin bar, is the person who worsened. So in patients who were started on cannabidiol, you can see here at the end of 6 months, the blue, that is responder, was quite high as 38%, and another good 10% had a non-response, and very few were non-responders. So good amount were responders. Now in the responders, if you break up to seizure-free, 5% became seizure-free. So if you look at the original Kwan and Brody study, the third anti-seizure medicine produced seizure freedom in 5%. The first produced in, say, 25, 30%. The second, 30 to 40%, the second produced in another few percent, and the third anti-seizure medicine produced in 5%. So the effect of cannabidiol in adults with epilepsy was equivalent to the third drug being added in the original Kwan and Brody study. So 5% became seizure-free, and a reduction of 80 to 99% of the seizures in the seizure chart was seen in 32%. And reduction between 50 to 79% was seen in 50%, which is very good. And less than 50% was seen in 11%. And in about 2%, there was an actual increase, which could be related to various pharmacokinetic mechanisms, which have been talked by the previous speaker. About 34% reported mild adverse effects, which were not significant enough to stop the medication, and none reported severe adverse effects. Hence, the study, which was an open observational study, concluded that adjuvant treatment with cannabidiol was effective and safe and can be used in adults with epilepsy. So now let's go on to various syndromes in which it has been tried and how safe it is and what is the efficacy. So if you see, all these syndromes have been spoken about by the previous speaker, whether it's Dravet, whether it's LGS, whether it's tuberous sclerosis complex. Now we do see children as going to adults because many of them are not referred for surgery, for removing the active tuber. So they reach adulthood. We also see CDKL5. I have 2 adult patients with this mutation, and we were waiting for the molecule to come. One of my residents, Anish, has worked up these patients, and he WhatsApped me as soon as your cannabidiol was released, and he said, "Madam, now it is available. Can we use?" I said, "Call the patient to OPD." So we'll start. So many of these patients do reach us even at an older age. So I think based on the safety and efficacy, it should be used even in these syndromes when they reach the adult age. Now, if you look at this study, which is Oren Devinsky has done the maximum amount of work on this, which is published in 2016, you can find a 36.5% reduction of the median number of motor seizures. And motor seizures are the seizures which actually trouble the patient. The adverse effects being somnolence, decreased appetite, diarrhea, fatigue, seizures. And you can see here some of them had status epilepticus. So you have to be careful about this and monitor the patients at least in the initial part. Again, going back to the pediatric studies, which have been summarized by Oren Devinsky here based on various syndromes. So you can see here CDKL, and you see at 48 weeks is the light gray bar. So there is an improvement in the seizure response compared to 12 weeks. So you should at least wait for a good 48 weeks before the response can be reflected. It's not just 1 or 2 weeks, it's 48 weeks where you would see that there is a slightly better response than at the beginning of the study, or 3rd month of the study in any of these pediatric syndromes going on to adults. If you look at the systematic review of seizure freedom with cannabinoids, 14 observational studies where the range of age ranged from 6 months to 46 years. So the systematic review also included adults. And you can see here, I told you the first observational study, 5% became seizure free. In the systematic review, there were 8.5% which became seizure free, which is not a bad number for a 3rd agent to be added. And you can see here that many of them had some amount of, the main side effect was the transaminitis and the gastrointestinal and sedation. In the cannabidiol was withdrawn in 9% versus 1.3%. So some of the side effects did result in withdrawal of the cannabidiol. That should also be remembered. Serious adverse effects, you can see here that there was a more chance of a serious adverse effects when drugs like valproate, and we know valproate, whether you add it to topiramate, whether you add it to zonisamide, the ammonia levels are pushed up, the valproate encephalopathy increases, we have to reduce the valproate doses. So in the same way, valproate co-therapy induced more amount of transaminitis, and I think valproate is a pretty much used drug in pediatric practice because it's a very effective drug. So one has to be careful when we use this along with valproate and monitor patients in the long term, particularly in on the hepatic functions. Again here, if you look at long-term efficacy over 96 weeks, so we talked about 48 weeks, now this is 96 weeks, and you can see here that it was pretty much effective in terms of the seizure reduction as well as the efficacy and tolerance. I would conclude my part of the study by saying cannabidiol is being launched for epilepsy. We will use it for drug-resistant epilepsy. In adults, we may have to be wary of the costs involved. We may also have to be knowing that only 5% may have complete seizure freedom, but a good 35 to 40% will have more than 80 to 90% seizure reduction. And that is not a bad number for a 2nd or 3rd drug to be added. However, you have to be careful when using it with valproate and clobazam. We know that clobazam also pushes up the the levels, and there can be interactions there. But apart from that, many of our patients are already using artisanal form of cannabis from the counter, from Ayurvedic prescriptions, from herbalists, and they're being used for various conditions, particularly chronic and pain, which is not responding to anything. So we do have patients who have chronic pain. There are studies. Again, these are studies which have been used for very severe pain like cancer pain, diabetic neuropathy, which is very refractory, fibromyalgia, and it is useful there. Then it has also been studied in chronic pain in various, placebo-controlled trials, as you can see here. And the number of patients has ranged from, 1,000 to 700. And there has been a reduction in the pain intensity of more than 30%. So it may be another molecule for use in refractory pain, which is not responding to your usual medications. The other use which people have been already using prior to its even being, formulated and given to us now is in spasticity. And many of them have been getting it from abroad, particularly spasticity in MS. We find that many patients are able to procure it from outside, and it has been shown to be effective in spasticity of MS. So if you look at these placebo-controlled trials, you can see a 50% reduction in spasticity and improvement in walking scores. So that's another indication, pain and then spasticity. Then, of course, it's been used in ALS, particularly when the ALS is troubled by very severe fasciculations and pain and cramps, which disturb the patient's sleep as well as the caregiver's peace of mind. So and leads to depression. So it has been found that use of cannabidiol, and there have been, I don't expect you all to read this. The first study showed no significant improvement, but subsequent studies have shown an improvement, and they consisted of about 50. The last study which showed an improvement had about 60 patients in it. In Parkinson's disease, particularly with the motor symptoms, fluctuations of dystonia, dyskinesias, and fluctuations, and severe non-motor symptoms like anxiety, sleep quality, hallucinations, and disorientation. Here again, you look at the doses, it's pretty high, 400 milligram a day. So you really have to use a lot of cannabidiol, but it has been found to be effective. And you can see here, it's not just case series. Initially there were case reports, but later on you have Carroll, which has done a randomized placebo control study, albeit on only 19 patients, which showed no significant effects. But then as you progress, you find that there is another randomized study which shows a significant difference in the scores in Parkinson's disease, non-motor symptom improvement. So it has been used in Parkinson's disease also, as you can see. In Alzheimer's disease, particularly in improving agitation, nocturnal motor activity, disturbed behavior, anorexia, and the patient's global impression of change. Again, you can see the number of studies here. Not very large, 24 is the largest number. And there's a significant reduction in nocturnal motor activity. So you can imagine Alzheimer's disease patient who's wandering about, who's not resting at night. So if the patient is able to reduce the nocturnal motor activity, then the caregiver also gets to sleep. So there had been a significant improvement in this study, which was a randomized placebo-controlled study. So you see that and even in children where it has been used, behavioral improvement has been found. In fact, sometimes the behavioral improvement outshines the seizure improvement. So definitely it has a effect on behavior, not only in children, but also in adults. It has been found to be pretty safe in most of the other studies, whether it's for PD, AD, etc. And you have to adjust the doses according to the hepatic involvement. So if you have a patient who has a mild hepatic, you would change the doses to 5 milligram as starting, and then 10 milligram, and then a maximum go to 20. But if there is severe hepatic involvement, you would just go up to 4 milligrams per kg in the severe hepatic involvement. So there is a formula for that which can be used. It's not that it's contraindicated in hepatic involvement. It will be useful to keep this chart when you're using it, so that if you have a patient who's already on valproate showing a hepatic involvement, you can start with the lower doses and go and build up to the lower doses. I conclude by saying that the evidence in adults is not too much, but it is enough to warrant assurance of the caregiver that there may be a 5% seizure freedom and a 35 to 40%, 80 to 99% seizure reduction. And it has a broad indication in drug-resistant epilepsy in adults, but particularly in children, it has a specific indication of particular syndromes like Lennox-Gastaut syndrome, Dravet syndrome, certain mutations, Rous syndrome, etc. And it should be used maybe as of now, I would recommend it as a third drug if the second fails, provided the patient can afford it and tolerate it. I think with this, I'd end my talk, and we can have discussion or questions. Thank you.
Thank you, Dr. Manjari. It was not an easy topic. In children, it is easier than in adults, especially cannabidiol. And she has beautifully covered not only epilepsy, but other neurological disorders also. Where it has found a place, it's finding place more strongly in these indications. But we have to weigh between the already therapeutic armamentarium available plus addition of this medicine for say ALS, Parkinson's disease, or toxicity of multiple sclerosis, etc. So this is open for question, and I'm also happy to note that Ivan is still online. Thank you, Ivan, for being online. And any question from the floor, then we'll ask Professor Ivan opinion also. Any questions? Is Professor Ivan online? Can you bring in? Manjari?
I am.
Yeah.
I'm still here.
Yeah, Ivan, I have one simple question, maybe silly question, maybe stupid question. Why cannabidiol is available only in solution form?
That is a good question. And I apologize. My again, technical errors. My video has now stopped working. So I'll try to convert over if we get a pause. So that's a good question. As opposed to I guess other formulations, for instance, tablets or whatnot. I mean, I probably don't have straight answers here, but given that cannabinoids are quite lipophilic, there's probably some industrial, problems in terms of converting those into, let's see. Oh, there we go. That worked.
Oh, you are there.
Converted. Yes, there we go. Into tablets. That's probably been one problem. There's probably, again, this is above my pay grade to understand this, but I guess an IV formulations would be the same. Now, there are products available that become sprays. Nano-emulsion products are available as well. So nano-emulsified cannabinoids. So again, that's putting, the component into micelles and certain nano-emulsified particles. And there are oils that become sprays. That's another way that they're available. They're available. You can get them as edibles. So as they can be formulated into gummies, and that might, in time be advantageous for children. So a lot of problems I run into are especially children with autism, or those who have sensory, hypersensitivities. They don't like the taste of the oil. It can taste a little bit earthy. So that's a problem. But that's a good question. In other formulations, it probably has to do a lot with the lipophilic nature of cannabinoids.
Yeah, thank you so much. Because it's likely that if it comes in, say, parenteral formulation, it may become more economical than being only in solution. So that's my view.
Yeah. Well, one strategy I do use for some patients, because the oil does not taste good for some. So if you can't tolerate that, again, this is very off-label. So that I'm speaking to this. Some of the companies will provide capsules, but they charge a lot of money for capsules. So if families can get a hold of capsules, vegetable-based capsules or gelatin-based capsules, depending on the dietary restrictions, you can put the oil into a capsule, and now you have capsules that children or adults or teenagers can swallow. So sometimes I advise on that.
Yeah, thank you. Once again, another a small question is that we have moved from innovator drug to generic drug in India. Now there are a lot of competition of this product coming in the market in solution formulation. And we are hopeful this will be very helpful, especially to, as I said, new kid on the block for the kids, as well as later adolescent and adults. We are very hopeful. And adults also, we have not tried our hands. Maybe like vigabatrin earlier and cannabidiol have been tried by our pediatric colleagues, even when it was not available in our country. So that way it will be, I'm hopeful, will be very helpful for people with epilepsy. Ivan, when when you were giving talk, I entered slightly late because of traffic in Delhi. Today there was no smoke, but there was too much traffic on the road. So you said that cannabinoid cannot be taken to any other country or traveling. I saw that. On 29th November, I was doing the web check-in for going to Hong Kong. And the first thing which flashed on the home page was, as per May 2023 order of the Aviation Ministry of Hong Kong, cannabidiols or cannabinoid are banned to be brought to the country. So even if suppose there is a patient and he's going to Hong Kong, he's going to settle there or visiting for 2-3 months, and he wants to carry this medication, which will be obviously, I won't say cheaper, more economical in India than Hong Kong. Mm-hmm. So what is the status in those situations?
Yeah, this honestly is one of the biggest complications I face with my patients, and it can be very destabilizing for them from their epilepsy point of view, and then just the family psychological point of view. It actually has prevented a lot of families from traveling and enjoying travel or going to visit family. To be honest, I have many patients from India, and that's been one very difficult kind of thing to navigate. How, what do they do? Because I can speak from the Canadian point of view. It is illegal at the federal level to take any cannabis product out of Canada. So you cannot do that. So it's a non-starter. So what do I do in that case? Well, first off, I have to, I work with the family to think of the destination. So, I have many colleagues throughout the world in different countries. So the first thing I'll do is if it's a country that I'm not familiar with, I'll connect with a colleague and I'll try to work something out there. So in the US, for instance, again, you cannot bring cannabis into the country. So what happens here as an example is I give the patient all the details about the dosing, how much, what they need to titrate up and wean off if they have to. So I give them a kind of a plan, and they will go to the state, and then they can order CBD in the US from a where it's legal in a particular state and have it delivered to them. So I kind of set this up and I say, look, this is what you have to do. Here's a place that I know, and they order it, they get it. So I think it becomes very dependent on the country. So in your example, I don't know, the laws about taking out of India. That's one thing to consider. Number two is in Hong Kong, how can you access CBD? If CBD, you would have to know the intricacies of in Hong Kong, how that's accessible, and then support the patient there. And like I said, in many situations, they just don't end up traveling. So I think we're going through a generational cultural shift right now in each country, in each province and state, in various countries and throughout the world. This is going to have to change. And I think it's going to come from groups of physicians like us, advocating on behalf of patients to say this is an epilepsy drug, and enough's enough. We have to support our patients in order to take these into other countries.
Thank you. No, it's available in Hong Kong, but you can't bring from any other country to Hong Kong.
Right.
That's
right.
Another intriguing question with my mind is that it's a prescription medicine now. It's a prescription medicine. If the doctor, because patient can take a lot of other medicines, and cannabidiol is the one which is not addicting. The first thing we are making a declaration or disclaimer that it is not addicting. Then in those situations, why it is not allowed to be taken when the patient is going anywhere, traveling? Or I could not find the answer. Yeah.
We have to go back to 1970. Richard Nixon made cannabis amongst many other drugs, Schedule 1. The world followed suit, on that basis. And those laws are now entrenched. So even despite it being a pharmaceutical drug, so in Canada, we're about to, we actually, Epidiolex was just approved. It will become available in the spring. And even with it being a pharmaceutical drug with a drug identification number, I'm still going to have to write very specific letters for patients in order for them to transport it out of Canada. And it's still not clear exactly if that will be acceptable. So it becomes very particular to the country. So I think depending on, that's something I think within India, you'll have to determine if it's going to be able to transport it out. But then that does not hold in other countries, because other countries, it's not an approved drug. And I think that's where the rubber hits the road.
I wish to congratulate Intas Pharmaceutical for bringing this. In the month of July, there was a joint meeting of Indian Epilepsy Society and Indian Epilepsy Association, where they have really brought information to us that it will be soon launched. And today we are seeing, and with your impactful talk, I think it's going to make a difference everywhere in the world, and especially in our country, which is in need of this medicine. And it is a generic now. In Canada, is it also generic in Canada, or it is still an innovator product, and by which pharmaceutical company?
Canada is we did the reverse. So it's very difficult. It's very different in Canada. In Canada, I have access to any single cannabis oil you could dream of, which is going to be very important. This is the next phase. So we're already kind of, looking towards the next phase. So in Canada, I've had access to cannabis. Well, we've had access to cannabis oils for children since 2016. Those are oils. We've had access to cannabis for children since 2013. So it's been a long time, and so actually the truth is CBD isolate, pharmaceutical grade CBD isolate has never been available in Canada until just this month. We just got approval. So everyone who works with cannabis in Canada does so not through pharmaceutical companies. They do it through what we call licensed producers of cannabis, and gets really complex for everybody. But essentially, there are license holders who can produce oils, and those oils or whatever other products can be available through a medical stream where we can access them. But they're also available recreationally, so you can buy them in stores.
Yeah, thank you so much. In when the presentation was done in Dublin from Jazz Pharmaceutical, Stoke, Stoke, Stoke Pharmaceutical, and some more. So there are a lot of discussion about the same, and I think they are marketing maybe in the European and part of North America, if not Canada. Yeah. So
So Epidiolex is what's going to be available via Jazz Pharmaceuticals. Yep.
Yes. So thank you so much, Ivan. It was wonderful, and we gained so much from your delivery of talk, and from my colleague Dr. Manjari informed us about usage in adult disorders, neurological as well as including epilepsy. So thank you very much, and I wish to thank Dr. Suhasini for asking me to chair the session. Thank you. Good night.
Thank you, sir. We now have a very brief panel discussion. I invite Dr. Saurabh Chopra to moderate the session. Dr. Saurabh is a very well-known pediatric neurologist and epileptologist in Delhi. He's currently working at Apollo Children's Hospital. So I invite the panelists. We have Dr. Swapan Gupta, who's Associate Professor of Neurology at GB Pant Hospital, and Manjari ma'am. Panel discussion. And Dr. Rakesh Jain, who's a pediatric neurologist working at Fortis Gurgaon. Slides? Slides नहीं है. क्यों उठा रहे हैं? Slides. Slides छोड़ दो आप. अच्छा. Project ना करें. हाँ. Projection बंद. Projection बंद कर दो. सबके ऊपर आ जाए. अच्छा वो नहीं देख पाएंगे. हाँ ठीक है. अब ठीक है. ठीक. अच्छा. नहीं मैं नहीं आ रही.
तो ऑनलाइन नहीं है.
Thank you, Intas, and thank you, Dr. Suhasini, for arranging this and also helping me introduce the panelists while things were getting arranged. So without wasting much time, so medical cannabis is a relatively new thing, but cannabis is something that all of us know since ages. Even as a child, bhang and weed was available everywhere. In fact, it was more easily available than probably nowadays. But for the approved product, obviously, we need a lot of approvals to come through. And luckily, now we are at a place where it is going to be available in probably the next few days. So it's known to have medical benefits since ancient times. Means Hindu culture has used it medicinally for a long time, much before in 1800s when its first documented role in seizures was that too was in fact from a Western traveler to India who documented that this is something that can be used for seizures. It was somewhere in the mid 1900s when the THC and CBD were kind of isolated, and that is probably also the time when it was labeled as a banned substance and it was labeled as having no medical use till fairly recently, which Dr. Manjari really went through the history quite well. So starting with the first question. The first question is for Dr. Ranjit. He's there. Dr. Ranjit is there. He's dropped out again. Okay. Okay. So basically, there are lots of artisanal products, as Dr. Manjari was talking about. There are lots of easily available food supplements, artisanal products in the market, and they are much cheaper. They are definitely much cheaper than what is going to be the cost of CBD in our country. So, Dr. Manjari, would you mind answering?
The artisanal products are made by different, different people, different levels. In India, they're being made by the herbalists as well as by naturopathic naturopaths as well as by Ayurvedic doctors. But one doesn't know how much of THC is there, how much of cannabidiol is there. One does not know how much, what is the purity, what is the impurity, what is the oil, carrier oil, which they're using. Nothing is declared in that. It's just written that this is, whatever, cannabis oil or whatever. And again, if you think that is inexpensive, it's not. It's pretty expensive. So it's not at all of medicinal grade. It's more of artisanal, or what you would call for, leisure purposes or whatever. So I don't think these molecules should be equated at all. There should be a complete dichotomy and clarity of what is medicinal and what is not, so that patients are also convinced, as well as the policy makers, because if this confusion enters the policy makers ki ye bhi de sakte hai, Baba Ramdev ka bhi de, ya kisi ka bhi de sakte hai, then there is no end to it, and we will not see the same effect. In fact, we may see some adverse effects, some reactions, which will give the medicinal one a bad name.
Absolutely agreed. If Dr. Evans is with us, would you like to make some comments on this point?
Certainly. Again, I think my video has been stopped. But I absolutely agree. And I think this has been the advantage of what's about to happen in Canada with the addition of a pharmaceutical CBD. And that's important. It's important in order to know what you have. At the same time, it's important to also recognize and keep an open mind that it appears via evidence, and again, we're going to produce some evidence as well for this, and there has been about throughout the world, that the other minor cannabinoids and THC also do play a role in the treatment of epilepsy and other conditions. So this is an excellent first step. It needs to be differentiated, and subsequently, when the other products become more widely available, or the proper trials have been conducted, we are going to also have pharmaceutical cannabis-based products, such that we can ensure the quality and the reliability of the product.
Thank you so much. So the next point I really want to understand, because in the West, CBD is quite regulated. It is prescribed by probably very few people who really have expertise in the field, but that's not how our country works. So Dr. Manjari, would you like to throw some light as to who should be prescribing? We really can't stop people from prescribing, but at least from a perspective of how our country works, who should really be prescribing it?
So I think pediatric neurologists and neurologists should be using the drug when it's meant for neurological conditions. Of course, cancer, pain, it will become oncology domain. But at least the neurological conditions should be restricted to pediatric neurologists and neurologists, because you would not give it as a first line. You would give it as a third add-on, or maybe a second add-on if you like it a lot in particular, genetic conditions. So you would also need to know the effect and the side effect, the drug interactions, and you can closely monitor the patient. And probably this kind of patient pool is going to be available with the pediatric neurologist and the neurologist. So they would be the only people who should be using it. And maybe once the patient goes, to a remote area or to the hinterlands, the prescription could be continued. But the first prescription and at least the first few follow-ups have to be with the neurologist and the pediatric neurologist.
Thank you. I think that was a good insight. Coming to the next question. CBD is not cheap. At least the pharmacological CBD is really not cheap. Not cheap in our country and probably not cheap anywhere else in the world. So, Dr. Evans, what's your take on the financial burden that this oil, this basically product has in your country? And then I'll come to ours.
Thank you. Very significant. Day to day, I'm trying to advocate on behalf of patients to companies to reduce costs. We've been successful in doing so, but it is quite expensive, and it's expensive in Canada again because we just got approval for that, for Epidiolex. But outside of that, because there's no approval at all for any cannabis-based medicinal product, it comes out of pocket for every family. And as we know, this population are already taxed significantly with costs of care for the children and adults in many of these cases because of how sick these children are and all the other supports they need. So it is not cost effective, in my opinion, at this point in time, and more programs need to be developed in order to support patients. And it adds a massive barrier because, again, I'm going to come back to my big points, right? This is working on an independent mechanism. We've shown that there is this 5 to 8% of seizure freedom, and so there certainly is an economic analysis here that needs to be conducted to show that this medicine should be covered.
And what do you think it will, how will this medicine be, say, 10 years or 20 years down the line in the armament of anti-epileptic drugs?
I think at present that it's going to be a hard question to answer. It could be an extremely effective precision medication in the future. And why do I say that? Because we've only just touched the surface with CBD. There are 135 different cannabinoids that all modulate the system in different ways. And I think what we're going to see is ultimately in time with cannabis-based medicine is you're going to have an idea of a person's endocannabinoid system and how that can be modulated depending on the way that it's been affected by the certain epilepsy underlying this. And then there will be, a very specific oil created for specific conditions, and even maybe based on the pharmacogenetics of that individual. I'll give you just a real solid example why I believe this. Dedi Meir, a very famous cannabis scientist from Israel, has discovered, he's got two TED Talks on this that are fascinating to watch, specifically with a very specific, I think it's a Notch 3 mutation in leukemia. There are 3 specific cannabinoids that reduce the cellular proliferation by about 90%. You take away one of those cannabinoids and the effectiveness reduces. You add a cannabinoid and the effectiveness reduces. You need those 3 precise cannabinoids. Again, it tells you the fine precision of this fine-tuning mechanism. Fascinating to look at, and I think that's the future of epilepsy care with cannabis.
Thank you. Thank you. Dr. Manjri, what's your take on the financial burden in our country and our setup?
So, considering the fact that we are probably the country producing the largest amount of cannabis. And
the plant.
Unofficially, I'd like to say, even in the AIMS campus, you find the cannabis just growing everywhere.
Yeah.
So I think that once it's established in routine clinical practice, it will be manufactured and produced just like any other pharmaceutical compound in India. And probably someday India will be, if not the first, the second producer of the molecule.
Yeah, good. That's very true, means.
So obviously the cost would come down, hopefully.
Hopefully, yes. So, yes, so there are lots of off-label uses. So Dr. Manjri highlighted some of the off-label uses. Dr. Evans also was talking about the off-label uses. We know a lot already from today's talks about the approved uses. So now going to the off-label use, Dr. Sopan, what do you feel where we are as far as the off-label use is concerned? Are we really there? And if so, in which conditions?
Yeah. So as we saw in the presentation, there are so many uses of cannabis or cannabidiol, which has already been used in so many conditions, like especially in pain management, in spasticity, in Parkinson's disease, Alzheimer's disease. But the limitations has been the availability because of the policy regulations, non-availability in different countries. non-purified form used in various unregulated forms, and also lack of real randomized control trials. Because of the obvious reasons, when something is not available freely, then it's difficult to perform a RCT. Yes, the evidence shows good results in these conditions, especially in chemotherapy associated pain, especially neuropathic pain, which are really difficult conditions to control. And yes, it does improve quality of life, especially in disorders, degenerative disorders like Alzheimer's, Parkinson's, where we have drugs which act on motor control. But what about the non-motor symptoms? What about the sleep quality? What about depression, associated anxiety? There, cannabidiol has a very important role. So I think with due course, as it is more widely used in epilepsy conditions and more regulated availability of pure medicinal cannabidiol and more liberal policy regulations, it is definitely going to be more widely used in these conditions as well. So yes, the future is bright. And yes, but we need more studies on that, large scale studies. And in times to come, it is expected they will follow.
Okay, great answer. Thank you. So, Dr. Rakesh, if you could throw some light on the pediatric side of off-label uses, especially with behaviors, we have lots of news coming in.
Yeah, we are yet to start our epilepsy, usage of cannabidiol, and I'm looking forward to it. Lots of patients, I'm sure, waiting for this medicine. But in pediatric, one is obviously regulatory issues are there. Autism is a big challenge, particularly when these children, they grow, they have a lot of anxiety, aggression, self-harm, sleep disorders. So I did see, few studies where they have, they were kind of observational studies where they have seen, all these, comorbidities, sorry, they've been addressed by cannabidiol, and they have been reduced actually, by using it. But still, it's a long way. We don't have any, information, any first-hand experience. So looking forward to it. But my question to the house is, uh, it is obviously off-label, and if you use it in autism or these kind of medicine, if something goes wrong, particularly it is metabolized in the liver. So as a medical practitioner, where do we stand in terms of medical legal issues and all? Maybe madam can put some more light on it.
I don't know. I think more or less one has to explain and have an informed decision making. And most of our patients have read, many of them have actually read because they are resistant and they are looking out on the net. So some of them ask themselves. And some of them are already taking it and you don't know it.
Yeah.
They'll bring out the bottle later. So
Maybe you could do a consent form like proper before we start medicine, particularly in off-label cases.
yeah, maybe in off-label cases, but generally, I don't think it's a problem. Dr. Pratibha Singhi ma'am has got so much more experience than me.
As long as you are convinced, you've seen, some of the studies that have documented efficacy, and you explain to the parents and they are willing. I normally write that, explained in detail and started with consent, if any off-label anything. So in terms of autism, we rarely need it, but certainly older children and adolescents where the usual things fail, and sometimes it can be very harrowing for the parents to have that sort of thing. If you want to try, I'm sure they will lap it up as long as we monitor properly and we tell them the side effects and everything, then it shouldn't be a problem. And I don't think a legal issue should arise with that once documented things properly, because it's like there in the paper, isn't it? So, and now it's approved for other uses. And in any case, autism spectrum disorder, in 30 to 40% of cases, they have all those EEG discharges for which some people have been using anti-epileptics as well, or anti-seizure medications, whatever you want to call it today. So serves a dual purpose. So no harm in trying in very select cases. You obviously are not going to use it as a garden variety product, but in very select cases, if it works, it works. Should not really be a problem. I don't have personal experience of using it, so I won't say beyond that. But certainly, I mean, there is a scope.
Thank you, ma'am. So yes, another thing that I just wanted to highlight was uh, there are two ways of producing it. Either you extract it from the plant or you can produce it synthetically. I was trying to get more and more information as to which one is going to be launched in our country. Initially, what I was being told that it's probably a synthetic product, but because the manufacturer is not the marketing company, so getting that information may take some time. But probably it's synthetic that is going to come into our country, whereas Epidiolex, on the other hand, is a plant-based product. So, and there have been research which has told us that patients actually prefer plant-based products because patients will prefer something that has been extracted from so-called natural sources, even though it has been fully processed
So just
and purified.
Sorry to interrupt, but I looked at him. I said, is this synthetic or?
So he was saying that it is plant-based. That is what he was telling me. But
Actually,
other companies have told me the other thing. So it's not very clear.
The plants grow like wild in so many places. It should actually be easy to produce it here.
It's only one manufacturer.
Right, the purified version, of course. So, I mean, it's like the ACTH thing, isn't it?
Yeah.
And so we can't sort of, equate one with the other because both of them would have different pharmacological and pharmacodynamic properties. So we need to know what we are giving.
Dr. Evans, would you throw some light on this?
Yeah, I'm very curious about that because if you look at the studies, right, that we're all deriving the indications from, that's not a synthetic CBD product. So I don't know, again, that would be strange for me. In Canada, for instance, I don't think a company could walk in with the synthetic CBD that hasn't been tried in the trials and use the trials from Epidiolex as phase 3 data to be approved in Canada. I don't know if that would be the case. So I would be surprised if there is a synthetic CBD that's coming to market, but I don't know. I mean, in Canada, I don't think so.
Okay, thank you. There have been some very few studies about this, and I think they are quite less to derive any conclusions out of it. So coming to the last part, I would ask all the panelists for their concluding remarks as regarding CBD and its launch in our country. Dr. Manjari, if you want to.
I think it's good to have the molecule. At least it prevents illicit procurement as well as consumption of artisanal forms. But as you said, the synthetic versus this thing, I was told it is plant-based. So,
okay.
Yeah. So I think we need reassurance that it is plant-based, and we should use it in patients with drug-resistant epilepsy. I would place it currently as the third add-on. And then we could build up with our experience, and confidence would build up in its usage.
Yeah, I agree with ma'am. We obviously have to get more information on it as far as our local data is concerned. And the cost will also come down gradually, I'm sure, when numbers are more. So it is good to have this medicine, in in our toolbox. And let's see, what our experience is. Thank you.
Yeah. So as we went through the panel discussion, it is very apparent that the major hindrances are the cost. But if we look at, there are two issues. One, in these patients, it's not just seizure freedom, it's about quality of life, which is more important. And second is cost. So if we look at first quality of life, if we see other anti-seizure medications, they do control seizures, but at the same time, they do not have any beneficial effect on their sleep, anxiety, depression, stress, which are real comorbidities in these patients. But cannabis or cannabidiol has an advantage over other anti-seizure medications because they, along with control of seizures, it also has effect on sleep, anxiety. It also reduces stress. So it overall is a good package if we talk about epilepsy, leaving even the other indications. Coming to the cost, again, these patients are drug resistant cases and they do require hospitalizations and again and again. And they do have status epilepticus quite often. So the cost, hospitalization cost, is much more than the cost of the drug itself. More so, it's our experience that these patients are so bad that their parents are desperate. They say, we are ready to spend money. Please get our child back. So compared to the other strategies like ketogenic diet, surgery, or even devices like VNS, they are much more expensive than this drug. So I think this drug, yes, is a very good hope in the horizon. And yes, obviously the real world data, we have to see, look at it. But the preliminary results, we all have not used it till now, but the preliminary results are very promising and we are looking forward to it.
Thank you. Thank you. Dr. Evans, any closing comments from your side?
Sure, yeah, and thanks once again. Pleasure to be here and an honor. I'll come back again, and I think I'm coming from this place as someone who's been using cannabis and CBD for several years. First principles apply. So I understand the hesitation and some of the nervousness that I'm picking up on, but it's very appropriate. You have to be familiar with the drug. It's like any other drug that comes to market. I think when everybody will begin, just use it, and when you start using it and working with it, you will see that it is relatively safe compared to other anti-epileptic drugs. It's easy to monitor, and in the end, you'll be able to fall into the idea that first principles will apply. So I think what the panelists have said, have put into context very appropriately. Start with little steps. Start, as a third line agent in the context of drug-resistant epilepsy for the indications you're familiar with. Start there, and then allow yourself to be open to expanding that practice. And I find it will come easily. And please feel free to reach out to me. Everyone is welcome. I think I put my contact information by my website there. I'm very happy to help. I mentor and guide a lot of physicians in the space throughout Canada and throughout the world. So please reach out. I'm very happy to support all of you. It's an amazing initiative. It needs to happen, and I'm excited for all of you to have this, another option in your toolkit to treat really complex and challenging situations in children where we really can improve their quality of life.
Thank you. So with that, we end today's session, and thank you all the panelists for sparing your time, and thank you Dr. Ivan for being an impromptu panelist with us. Thanks everybody.
Thank you, Dr. Ivan Lewis. Thank you, Dr. Saurabh, for moderating the session, and thanks to all panelists. And thank you all for coming today and attending this session. And I think we can go for dinner now. Thank you so much.
Bye, everybody.